Maybe you can make it full screen.
Yes.
Yeah, all good.
The topic given to me is rapid eye movement sleep behavior disorder. I will, in next 30-40 minutes, I will cover the initial approach and the various under these headings, the definition, classification, what is primary RBD, secondary RBD, investigations, and some of our publications and literature review in this area. To begin with, if RBD lies under the heading of parasomnias. And parasomnias are undesirable physical events or experience that occurs during entry into sleep, within a sleep, or during arousals. So if the parasomnias that occur during REM sleep are known as REM parasomnias, and they are clinical disorders because of injuries, sleep disruptions, adverse health effects, and untoward psychological effects. So the REM parasomnias are mainly three types: REM sleep behavior disorder, recurrent isolated sleep paralysis, and nightmare disorder. So what we are going to look at is REM sleep behavior disorder. And this is the landmark paper by Schenk and Mehowald, where actually this condition was described by them. And in this paper, they evaluated 4 patients of aged 67 to 72 years with a history of violent sleep behaviors and full description of dreams and polysomnographic picture. So they actually elaborated the whole picture of REM sleep behavior disorder in these 4 patients and described this entity. This is the picture of Dr. Schenk, who is a psychiatrist by profession, on the right side, and on the left side, Dr. Mehowald. And I had the opportunity to meet Dr. Schenk when he came to SleepCon few years back. And so why this is important actually, why this has gained so much importance, is that it is a harbinger of alpha-synuclein pathology. And the reports say, like in this paper, it can precede the onset of neurodegenerative disorder or alpha-synucleinopathy by almost 5 decades, maximum up till 5 decades. So actually it is a biomarker. And since alpha-synucleinopathies form the second most common cause of neurodegeneration after Alzheimer's disease, the interest has significantly grown in this area because this is considered to be a premotor symptom of alpha-synucleinopathy. And if we look at all the other neurodegenerative conditions, this is significantly present in a large number of patients. In questionnaire-based study on 661 patients, it was found that almost 40 to 41% of the patients had this condition. And what is the pathophysiology? So what happens actually is in normal subjects, the signals from motor cortex through the spinal cord go to the muscle and that leads to normal muscle tone. So this tone is actually controlled by locus subcellulose output through nucleus magnocellularis. In Parkinson's disease patient, what happens is basal ganglia is down. So in the normal situation, in the wake position, the tone is increased. Muscle tone is increased, leading, and also slowness is present. What happens in REM sleep in normal subjects is during sleep, output from nucleus magnocellularis inhibits the muscle tone, leading to atonia. But due to neurodegeneration at locus subcellulose, the output which supposed to excite the nucleus magnocellularis is gone. So what happens is there is REM sleep without atonia, and this is further explained by this in the next diagram. If you see over here, that the output is through the GABA or glycine pathways. So spinal motor neurons are inhibited in the normal REM sleep. If you look at the diagram on the right, what is shown as a dotted diagram is the one which is destroyed or damaged in REM sleep behavior disorder. So the tone to the spinal motor neurons is maintained, leading to the tonic EMG activity, phasic EMG activity during the REM sleep. Now, this is one of the typical polysomnography snapshot from one of our patients recorded in the lab. And here we can see it is REM sleep, and the EMG activity is seen along with the, and this is occurring during the REM sleep, like over here. And this is the video of the same patient during the episode which occurred. This is accompanied by vocalization and also violent motor activity, which is seen. And these are some of the other videos already published, because it's, even though RBD is present, to record a classical episode is not easy many times. So here the patient is hitting. So many videos are available in various publications. And this is another one. So this is characterized by patient is trying to, touch something, or so these are dream enactment behaviors. And these are some of in our lab which we have recorded. And it can only be subtle twitches, like for example, in the patient on the right, the video, we can see there are certain twitches. So classical vocalization and sleep enactment may be there, or it may be accompanied by twitches which are recorded in the EMG, like over here. In this patient, during REM sleep, the increased activity. So if we look at the epidemiology, lifetime prevalence of REM sleep behavior disorders in adults is approximately 15%, and prevalence ranges from 0.38 to 0.5% in elderly and general population. Longitudinal cohort studies show that already, as I have told earlier, that there is eventual phenoconversion to a defined neurodegenerative disease, predominantly alpha-synucleinopathy, or different phenotypes of PD, non-amnestic MCI, diffuse Lewy body dementia, multiple system atrophy. But as of now, there is no way to predict that the person will develop which type of alpha-synucleinopathy. And phenoconversion risk over 2 to 5 years is approximately 15 to 35%, and longitudinal follow-up between 12 to 25 years increases from 41 to 90% almost. Risk factors of REM sleep behavior disorder: male gender, elderly age, neurodegenerative disorders, stroke, and other brainstem structural lesions, autoimmune encephalitis. Because if you look at the etiology which I showed earlier, any lesion also at that place, for example, a small stroke, which disrupts that circuit of inhibition, will lead to REM sleep behavior disorder. Even in autoimmune encephalitis, the same etiology can be present. Also, smoking, head injury, pesticide exposure, farming, and medications like antidepressants, venlafaxine, SSRIs, mirtazapine, beta blockers, anti-acetylcholinesterase inhibitors, and selegiline can lead to REM sleep behavior disorder. Clinical presentation is usually with sleep-related injury to self or bed partner, dream enactment behavior, both violent and non-violent, awakening quickly from the episode and dream recall, and most of the patients have combination of these symptoms. If it is one of the episode of injury that brings the patient to the doctor. If we look at the classification of REM sleep behavior disorder, idiopathic RBD is around is what I have. They present only with REM sleep behavior disorder, and as per the data, 80 to 90% will develop alpha-synucleinopathy in due course of time. Then comes the secondary REM sleep behavior disorder, which whatever we encounter is drug-induced or in part of neurological disorders. Among the drug-induced, SSRI drugs, tricyclic antidepressants, beta blockers, alcohol withdrawal, these can cause secondary RBD. Barbiturate withdrawal, If you look at the neurological disorders, already existing alpha-synucleinopathies like PD, DLB, MSA, they can have REM sleep behavior disorder, or focal lesions in the brainstem due to stroke, multiple sclerosis, and structural lesions like small cysts or tumors also can lead to secondary RBD. This is a long list of the conditions which can be associated with REM sleep behavior disorder. As you can see, long list of neurodegenerative disease. So actually, what we should understand from this is that the pathology itself is disrupting the circuit, whether it is alpha-synuclein or it is tau deposition or it is copper deposition or any such deposition in the brainstem. And autoimmune disorders, it is associated with the various Eglon 5 disease, anti-MA1-2 encephalitis, and various conditions. And the structural brain lesions on the right, second table, if we see ischemic infarct, hemorrhage from cavernoma, tumors, demyelinating plaques, limbic encephalitis, and the drugs which I have enumerated earlier. So the criteria which we all follow is from ASM, repeated episodes of sleep-related vocalization and or complex motor behavior. And these are documented by polysomnography to occur during REM sleep based on the clinical history. Polysomnographic recording demonstrates REM sleep without atonia, and the disturbance is not better explained by any other sleep disorder, mental condition, medication, or substance abuse. So if there is a new concept of prodromal RBD which has been given to look at whether prior to RBD there is another phase where as the RBD evolves. So the single minor movements in video polysomnography are seen in normal people also, and EMG single twitches are often associated with REM sleep behavior disorder. But prodromal RBD is when more than two of these movements are present, increased tonic and phasic EMG activity, but no cutoff has been defined. Then the idiopathic RBD, which a lot of cohort studies are there, which meets the video criteria for RBD, and then the overt alpha-synucleinopathy. So if we try to look at the evaluation of a case which presents to us with suspected REM sleep behavior disorder, we evaluate for dream enactment behavior, vocalization, history from bed partner, sleep-related injuries, complex motor behavior during sleep, and then evaluate with video polysomnography to look for REM sleep without atonia and dream enactment behavior. RBD screening questionnaire can be applied for improving the diagnostic outcome. Subsequently, if there is a history of recent SSRI, tricyclic antidepressant, or alcohol uptake or barbiturate withdrawal, we label it as drug-induced RBD, and we advise behavioral and safety precautions and stop offending drug symptomatic treatment. Follow-up strategy based on the risk factor assessment is individualized. If the examination shows Parkinsonism, then we consider it as secondary RBD. Neurology consultation is done and we look for stroke, brainstem, whether it is classical Parkinson's disease, and accordingly manage. In case there is normal neurological examination, then we label it as idiopathic RBD, and we perform the DAT scan, smell test, constipation, depression to look for prodromal alpha-synucleinopathy. And this is continued every 6 monthly as of now, which is the recommendation, and annually, and advise the neuroprotective therapy like adequate sunlight exposure, healthy lifestyle, exercise, because there is no way as of now to prevent the conversion. So these are the patients who are actually undergoing a lot of drug development is occurring in this area to stop this progression somehow. What are the differential diagnoses? This is a list on the left side: sleepwalking, which can be differentiated because it occurs in NREM sleep diagnostic testing by PSG, sleep terrors, nocturnal seizures, obstructive sleep apnea, where pseudo RBD phenomena can be seen, rhythmic movement disorder, sleep-related dissociated disorder, hypnopompic hallucinations, PTSD. But as you can see, they can be ruled out by polysomnography or adequate history, and examination findings. And sometimes EEG and MRI would be needed, like in nocturnal seizures. The drug of choice is clonazepam, as it's basically anti-epileptic that has GABA agonist activity and enhances the activity of GABA. Uh, and clonazepam acts by reducing the REM sleep duration, increasing the NREM sleep percentage, thus reducing the RBD attacks. Second drug is melatonin, which is, as you are aware, is a natural hormone, and it is available as 3 mg and 5 mg tablets. And there is both the drugs can be used in one by one, clonazepam early or melatonin in patients accordingly. And these two are the main drugs. In secondary RBD, the treatment is done based on Parkinsonian drugs, levodopa, carbidopa, dopa receptor agonists, along with clonazepam and melatonin. Behavioral alterations, the bedroom safety precautions should be taken. Bed should be well cushioned. Adjacent floor should be, no sharp objects should be present. Bed rails with cushions will be useful. And the bed partner should take precautions and consider sleeping in separate room in case of sleep-related injuries are noted to bed partner. Now, as you saw in the flow chart, that DAT scan is recommended in the evaluation of idiopathic RBD. Now, there is significant evidence as seen in this review paper, where it has been found that many patients of these have presynaptic dopaminergic neuroimaging deficits, and these are the patients which are being evaluated for neuroprotective drug trials. And the type of abnormality that is found is reduced uptake in putaminal level. So this is from a published paper where a patient after diagnosis of RBD 1 year later, the findings seen in the presynaptic imaging, and 3.5 years later as compared to controls. If we see in control, there is normal bilateral putaminan caudate uptake. And over here, if we see 1 year later, there's a reduction in uptake, and over 2.5 or 3.5 years later, there's significant reduction in the dopaminergic presynaptic uptake of the radionuclide, showing that there is a sustained continuous reduction in dopaminergic receptors in patients with RBD. So this is just the gist of the treatment which we discussed earlier. Idiopathic RBD, first line is behavioral therapy, second line is clonazepam, and according to severity, and that has to be increased, and regular 6-monthly follow-up. Secondary, with cessation and replacement of causative medications. If there is a lesion associated or alpha-synucleinopathy present, still clonazepam remains the drug of choice. Now, some of the literature in secondary RBD, patients who have Parkinson's disease and have RBD coexisting with that. So presence of RBD in patients with Parkinson's disease is important because it determines a different phenotype of Parkinson's disease. And in various papers, which I'll discuss here, like in this paper, they found that patients who have RBD tend to have specific motor and non-motor manifestations, like higher frequency of freezing and falls, akinetic rigid disease phenotype, depression, constipation, decreased color vision, autonomic dysfunction. So they have a more severe type of phenotype. And in the other study, in this study also, they found that they have orthostatic hypotension, mild cognitive impairment, RBD, depression, anxiety, and more of malignant phenotype as compared to the patients who do not have RBD. So RBD is a marker of higher severity in patients with Parkinson's disease. Now, from our center, Dr. Rohan evaluated a group of patients with questionnaire study in young onset PD versus old onset PD. And it was found that RBD was more common in the old onset PD, along with the other non-motor symptoms. Recently published, one of our Dr. Amitabh has done one study using the um, TMS, and it was found that the PD with RBD patients had greater inhibition and reduced intracortical facilitation, suggesting enhanced GABAergic and reduced glutaminergic transmission, which is responsible for pathophysiologic process observed in these patients. As I told earlier, the secondary RBD can also be seen along with autoimmune encephalitis. So this is one of the studies which we did at our center as a pooling up of patients with Morvan syndrome, Casper-2 related Morvan syndrome, and 14 patients were evaluated. What was found that polysomnography was available in 6 patients, insomnia was present, absence of deep sleep, high frequency of beta, and REM sleep behavior disorder was significantly present in these patients. In women with RBD, in another study from our center, the women with probable RBD were older, had shorter duration of PD symptoms, lower tremor score, and higher axial sign score. They had insomnia and poor sleep quality with excessive daytime somnolence. The dream content in the women was with fewer fights, less aggressive dream enactment behavior than men, but suffer from significantly disturbed sleep and higher levels of anxiety and depression. We also looked at the cognitive functions in patients with RBD. Dr. Nitish worked on this in his thesis, and he found that there was significant impairment in MMSE, category fluency test, frontal assessment battery, attention span, verbal memory, and these patients also had poor sleep quality. Now, if we look at, as told earlier, these patients have high probability of developing early dementia, as shown in this paper by Postema et al. And the outcome and early death is also more likely in patients who have PD with RBD. There is another study interesting, only one I could find, where the motor signature of RBD is determined as shown as limb wrist with flex digits, which is seen in 50% of the patients. So if we look at this video, if we look at the left hand, there's a kind of wrist drop kind of appearance. So this is suggested as a motor signature of REM sleep behavior disorder. On comparing the hormone presence of testosterone with RBD, there is no association has been found. The dream phenomenology in Parkinson's disease was evaluated, and the following content of dream has been found in patients with RBD: chased by a person, chased by animal, defense against attack by person. So these are the common type of dream content: family, daily activity, vivid dreams, work-related, and space, and some of them are bizarre. These are the type of phenomenology of dreams. And in males versus females, there is a difference in the type of dream phenomenology. By gender, if we was seen in this study, so they found that the daily codes and the family daily activity type of dreams are more common in females as compared to the violent dreams in the males. There is association between visual hallucinations, RBD, and cognitive impairment in this review paper by Dr. Abhishek Lanka from our institute. He has tried to hypothesize why the patients with PD with RBD have more chances of psychosis and visual hallucination, as well as the MCI. So there is a connection between the cholinergic dysfunction and degeneration in Parkinson's disease and all these three conditions. So older age, akinetic rigid phenotype, excessive daytime sleep, depression, autonomic dysfunction, longer duration of disease, higher Hone and Yar. So they form a kind of interconnecting relationship, have an interconnecting relationship between all these three factors in patients with PD. In other atypical Parkinsonism, like if we look at MSA, PSP, also there is significantly high presence. But if we look at MSA, it is much more higher as compared to the PD. So these are the various studies which have evaluated in atypical Parkinsonian syndromes, especially in MSA. So I think so. The take-home message over here is that RBD has become an important biomarker in patients with alpha-synucleinopathies. Early identification helps to manage the patients, and drug-induced RBD or secondary RBD should also be considered in differential diagnosis and should be treated. Idiopathic RBD is substrate for development of potential neuroprotective therapies. That is why identification of idiopathic RBD is very important. So my acknowledgements, my collaborators, Dr. Bindu Kutti, lab, Dr. Pramod Pal, and all the other students and colleagues who have are working in this area from NIMS. Thank you for your attention.
Thank you, Dr. Ravi Yadav, for that very nice talk. I think let us see some of the questions in the chat box.
Yeah, so there is a question on how many epochs of REM sleep without atonia. So actually it is, as of now, 50% of the whole 30 seconds epoch if we take. So it can be divided into mini epochs, like 3 3-second epochs. And then out of that, 50% or more should be taken. If there are 1 or 2 mini epochs, they are not considered. But it should be, if we consider the whole epoch, almost 50%. It can be as a combination of mini epochs or a sustained during the whole epoch. That is what is the criteria. That slide actually I forgot to show, where the ASM has clearly told this.
I just wanted to have a discussion with you regarding this RBD in alpha-synucleinopathies. So, so what is the treatment option for that? Suppose if you diagnose first RBD.
Yeah, ma'am. Idiopathic RBD as of now is just symptomatic. Clonazepam is just given to reduce the REM duration. It doesn't do anything. It doesn't change the trajectory of degeneration. It just shifts from reduces the REM sleep. And so what happens is automatically the RBD episodes come down. The patient is relieved symptomatically just by shifting from REM to NREM. But actually the degeneration is continuing. That is not stopping at all.
Yeah.
So for that, the healthy lifestyle as of now, coffee and healthy lifestyle, antioxidants, all those are recommended, but no one knows whether they have any role. So the most important thing, we should have a large, our cohort of idiopathic RBD patients identified. And then we have to look at, from Indian perspective, different therapies or can be tried. And as I told earlier, large trials are going on, and to evaluate how can we stop at this moment when the neurological examination is normal.
Yes. Yeah, but some prophylactics we can think of.
A lot of things can be thought of. Yes. I think Rafiq has asked, so if we have a couple of epochs with RSWA, young otherwise healthy patient with no medication, it may be. So a couple of epochs is not. If it is 50% and above and classical history of vocalization, dream enactment behavior is present, then only we should consider. If it is, we have to look at secondary points then and correlate, because in the criteria, there is a combination of vocalization, dream enactment behavior, and evidence in polysomnography. So we have to look at why polysomnography is done. He has asked, only on PSG, if it is there, then we have to see what is the other reason, medication or like SSRIs, tricyclic, all antidepressants, they can also cause. So combination has to be checked. And then if to label idiopathic RBD, smell testing, constipation, and even MRI DAT scan, like it shows dopaminergic reduction. That all to combine together, we have to see. Because pseudo RBD is also quite common. In OSA, we see dream enactment behavior. So we cannot jump straight away to say that it is really idiopathic RBD.
I think no more questions now.
Right. Thank you so much, ma'am.
So thank you. Yeah, thank you so much.